All right. All right. So, hello, everybody who's here and those who will be watching at home later. Um, we're going to continue in our virtual lecture series and discuss obstetric hemorrhage, which is a very important topic for like all the things that we're talking about. They're very important clinically and very important for your examinations because obstetric hemorrhage is still very much a problem in the field of obstetrics globally, even in the most high resource centers. This is a challenge for us. And while we have many options that are specific and ways to manage uh, these sort of disorders, this is the bulk of what the challenge is for an obstetrician when managing labor. And the important things to understand about obstetric hemorrhage is that the hemorrhage occurs uh, for specific reasons. Understanding why there's bleeding is going to be the biggest and most helpful indicator about how you treat it. So, like most things in obstetrics and gynecology, understanding how and why these situations are occurring will help you. And most often, the function of the actual organs themselves will give you a clue. This is for the ovaries or the uterus, because as I've said before, the uterus will do one of two things. It will expel something that doesn't belong, or it will accommodate a pregnancy. So when there are problems related to those functions, there will be bleeding. But let's first begin by talking about more broadly bleeding in pregnancy. So it's important to remember that bleeding during pregnancy always requires evaluation. That doesn't necessarily mean that it's always catastrophic and that there's going to be it's underlying of a more significant and threatening pathology, because bleeding from the vagina is a common event really at all stages of pregnancy. Now, um, profound hemorrhage is not, but bleeding is. But regardless, even spotting always requires evaluation. So it's not particularly something that is considered normal and you could shrug it off. Um, in evaluating bleeding for a pregnant patient, the diagnosis is usually based, it can be more readily identified by a patient's gestational age and the character of the bleeding, mainly if it's light or heavy, associated with pain or painless, intermittent or constant, are um, important characteristics to be aware of because they actually do follow closely with the clinical scenario that you're dealing with. Generally, what I tell a lot of my obstetrical patients is when they're given quote unquote bleeding precautions, that bleeding like a period during pregnancy is never normal. A heavy flow like that is never a normal thing. Um, so that's something that is helpful from a practical standpoint. But so when you get a history of a pregnant patient who's presenting with bleeding, you ensuring that you get the patient's gestational age and the character of her bleeding in addition to your historical items is probably going to be the highest yield in terms of telling you what actually is going on. Um, like when we get into our discussion about abnormal uterine bleeding, which isn't usually in the context of the non-pregnant patient, which is referred to as gynecologic disorders. Gynecology is usually, that term is reserved for the non-pregnant patient, where obstetrics is reserved, excuse me, um, for the pregnant patient. Okay, so when we have that discussion, we'll be dividing those sort of situations by the age of the patient, so the patient's age, as opposed to in obstetrics, the bleeding will the bleeding situations will be determined more by the fetus's age, so the gestational age or the trimester of pregnancy. Okay, you can divide it into those categories in a reliable way. This actually comes from ACOG's practice bulletin for both scenarios, so that's where it's recommended. So when you're doing studying and trying to understand these things, categorizing them by their for obstetric bleeding disorders or obstetric hemorrhage, I should say, bleeding disorders implies more of like intrinsic disorders like clotting in the hematologic system. If you organize your understanding by trimester, it's something that is both clinically relevant and also for your examination. Sometimes, especially for board study, to organize things into broad categories sometimes is helpful for examinations, but not necessarily for the clinical scenario. This is not one of those times, okay? It applies to both. So in the first trimester, which is the beginning from to 13 and 6 weeks gestational age, as in 13 weeks completed in 6 days, about 20 to 40% of women will experience bleeding. In the first trimester, there's about 4 major sources of non-traumatic bleeding. Because keep in mind, if you have trauma, meaning that you had a fall or there was an altercation or a motor vehicle accident, bleeding from that is related primarily to the trauma itself. But non-traumatic bleeding is associated with a couple of things, but the ones that are most important for us are ectopic pregnancy and early pregnancy loss, which is miscarriages. In addition, when the pregnancy implants, you could have some spotting, or even when you have polyps or inflammation or infection. This is kind of related to sexual transmitted diseases, and then also trophoblastic disease, but that's usually this is related also to early pregnancy loss, things like molar pregnancy. Excuse me, molar pregnancies and things like that. That's also related to early pregnancy loss and miscarriages. They have the same sort of workup. Remember with trophoblastic disease that the most common presenting feature, say for a molar pregnancy or a partial molar pregnancy, is vaginal bleeding. So that's also something to keep in mind. But the bulk of what you'll be encountering in your first trimester bleeding will be to rule out an ectopic pregnancy or a miscarriage. There'll be a separate talk about ectopic pregnancies because that really falls under the realm of gynecology. But first we're going to describe different types of miscarriages. This is a bulk of what you'll see in the emergency department and also on your examinations. So in the first trimester, we're most concerned with either determining if bleeding is due to in a patient who you've determined to be pregnant is either associated with something that may end in a miscarriage, or if there's uncertainty about if there's even a pregnancy within the uterus itself, that you may be dealing with an ectopic pregnancy. Ectopic pregnancy being that there's a pregnancy outside of the uterine cavity. So in terms of miscarriages, the way that you can think about these is to relate the situation in terms of what the cervix is doing and the status of the fetus inside, okay? So and these are referred to as abortions as well, okay? Abortion being that there's some abnormality with the pregnancy that has to end. Abortion is usually associated synonymously with like a voluntary sort of termination of pregnancy, but abortion generally refers to all of them, okay? So just keep that in mind when you're using that terminology. So a missed abortion is what it's going to be called, is when you have a closed cervix. So the cervix is closed and you had a fetus otherwise that at some point had cardiac activity, but now doesn't, okay? You want to think about it in terms of like missed as in the transition between the viability of the fetus and now your situation here, you miss that transition. That's why this terminology is used, or at least that's the best way I think of it. Here it says there's no vaginal bleeding, but you can have spotting, especially when if you have a mist and um, the uterus is preparing to try to expel the products of conception. You may have some spotting, but not always necessary. But you'll have a closed cervical os, and you'll have either a crown rump length fetus with no cardiac activity, or an empty sac, which is it'll just be a gestational sac with no contents. You have to be careful with an empty gestational sac because um, there are situations where it's not that it's a missed abortion. It's just that the pregnancy hasn't progressed long enough for a fetus to be seen or developed, or a yolk sac in that case. There is always a discussion about something called a discriminatory zone for the level of beta HCG, which we'll discuss, the pregnancy hormone, which we'll discuss in our ectopic pregnancy lecture. But anecdotally, I'll tell you that a single isolated value of a beta HCG level and the presence of an empty gestational sac on ultrasound, uh, always it's most prudent to get a follow-up within 48 hours to trend the actual level to ensure that you're just not dealing with a normal pregnancy. Um, but in the context of this discussion, that is how we'll categorize a missed abortion. Okay. And if anybody in the audience has any questions, please feel free to interrupt me or put in the chat box. But otherwise, we'll record this for those who will review it later at home. A threatened abortion is really the presence of vaginal bleeding with a closed cervix, but otherwise normal fetal cardiac activity. The fetus, from a fetal standpoint, fetal well-being standpoint, everything is normal, right? You have a fetus with a crown rump length. And when I say crown rump length, that basically means that you just have a discrete fetus. A crown rump length is how you measure, you can measure the fetus in terms of trying to determine the gestational age in the first trimester. So you get from the crown of the fetus here to the rump, that length will correspond with the gestational age. So common terminology is to say it like that, but that's what I mean when I say that. So you'll have an otherwise normal fetus with appropriate cardiac activity, and you'll see fetal movement, the cervix is closed, but you have vaginal bleeding, which is abnormal in any circumstance. So that's what's threatened. If you have say for example, this terminology does extend up to 20 weeks, okay? So even you can have sometimes a fetus who's say 18 weeks gestational age, and that's a pretty well formed fetus at that point. But if you have vaginal bleeding in that context, it's still a threatened abortion, okay? Once you get beyond 20 weeks, that's when terminology begins to shift into terms like if you had a fetal demise at that point, it would be called an intrauterine fetal demise, for example, as opposed to before 20 weeks, if you had a stillbirth, it wouldn't really in the second trimester, it would still be called a miscarriage. Just a bit of terminology things. But that's threatened. You want to consider threatened to be an otherwise normal fetus, closed cervix, vaginal bleeding, okay? Now, this next situation of an inevitable miscarriage is similar to a threatened in that you'll have vaginal bleeding, and you may even have a normal you may have a normal fetus, but if the cervix is open, and that's the most important part, if you have a dilated cervix in the first trimester or even the beginning of the second trimester, that pregnancy is not going to continue. When we get into discussions about cervical insufficiency, which happens in the late second trimester, those are opportunities where if you have a dilated cervix, you can there are options you can take in terms of trying to potentiate that pregnancy, which involves putting a stitch in called a cerclage into the cervix and a couple of other management strategies. But at this venture, at this gestational age, when you have a dilated cervical os, that's inevitable. That is a pregnancy that will inevitably result in a miscarriage. Okay, so that's how you understand it. The product's conceptions may be seen, they might be prolapsed in that they're not in the uterine body, but the lower uterine segment, but the cervix is open. Okay, but you'll have some vaginal bleeding, but this is different from, say, an incomplete miscarriage. An incomplete abortion is that when you have essentially this situation, but you have products being expelled. Okay, but incomplete being that some are expelled and some remain. So this is a progression here. So an inevitable would be where you have a similar situation to your incomplete abortion, but there's no passage of products, and that's really the important part. You have a dilated cervical os, you have vaginal bleeding, but you've passed some of your products. When you have a patient in an emergency department where they're coming in with hemorrhage that requires an emergency or urgent treatment via evacuation, which is called suction, dilation, and curettage, this is the situation which you're encountering because you have ongoing bleeding and you have products of conception that remain and it continues the hemorrhage, okay? So that's where your emergency treatments in the emergency department, that's your diagnosis that you commonly encounter. And then complete abortion, this is usually history driven because the deal is that there's nothing in the uterus and the cervix is closed. You might have some vaginal bleeding, you may not, but usually how you determine that the products were completely expelled is that either you have a documented pregnancy prior, the patient gives a history of heavy bleeding and usually passage of some sort of tissue. They don't call it that, they'll say some sort of spongy material. And then when you do your repeat examination, there's nothing else in the uterus and the cervix is closed. So that's your complete abortion at that point. All right. These are terms that are important. It comes up on your exam, and more importantly than that, it comes up in the emergency department. So being familiar with these things is very important. Okay. There's also something called a septic abortion, and this is in the context of a pregnancy that also has superimposed sepsis because of infection of the products of conception, okay? That's not a discrete entity here because it's really just an infection in the context of what's going on here. Generally, a septic abortion will occur in the context of either a normal fetus or like a threatened or an inevitable or sometimes an incomplete. But generally, for bacteria to thrive, there has to be living tissue, right? So it's usually in the context of a fetus that may potentially be alive in terms of having normal cardiac activity and otherwise normal status. But what you'll see is that in cases of a septic abortion, is there's abdominal pain, uterine tenderness, purulent discharge due to the infection, but also more importantly, there's the presence of sepsis. Here we're defining sepsis as your systemic inflammatory response syndrome criteria, which is fever or hyperthermia if it's ongoing, and then your maternal vital sign instability like tachypnea, tachycardia, So the reason why this is so important is because it can progress and be lethal too. And when we say lethal, we're meaning more lethal to the maternal in the maternal context. Yes, for the fetus as well, but a lot of obviously by definition we're talking about abortions, which is termination, which is results in the non-viability of the fetus. Here, it can lead to a maternal mortality. Um, Additionally, this could lead to ongoing hemorrhage. It could lead to bleeding, and that hemorrhage can continue and lead to something called disseminated intravascular coagulation, which we call a short for DIC, which I will explain most specifically in this series. But this is a situation that results in profound bleeding and has a mortality risk associated with it. And generally, ongoing bleeding in the context of obstetric hemorrhage, this is always a situation that is a threat and something we need to avoid. And we'll discuss the physiology, the pathophysiology and mechanism about why this specific situation happens and how we can prevent it. So much so that if ongoing bleeding results, it can require hysterectomy to stop the bleeding. But we'll discuss more in our at the end of this lecture when we go into postpartum hemorrhage, uh, how we prevent that step from happening. But prompt recognition of sepsis in relation to an abortus is important, and the treatment is. Oh, I thought I had it here. The treatment for a septic abortion is evacuation of the contents via suction D&C, and then antibiotics, in addition to supportive care, whatever that requires in terms of the maternal and fetal status. It sometimes it comes at a septic abortion simply presents with sepsis and these clinical findings of pain and especially purulent vaginal discharge. It's always very important to ensure that you are not missing an additional cause of sepsis. Um, if usually these cases are most readily identified with an otherwise normal patient in terms of medical comorbidities, um, and no other clinical signs and laboratory signs of infection of, say, the respiratory system or otherwise, then you know that. And ultimately, that involves termination of the pregnancy, evacuation of the contents, and the treatment, as I mentioned. So those are all of your the description of the miscarriages and the bulk of your first trimester bleeding that you need to know and review. So sit with that and understand the differences as you go through your question banks or even seeing patients in the emergency department when you're on your clinical modules here. That'll put it most clearly into your mind, and that will be present. Here's an algorithm that more or less describes everything we discussed. ACOG and OBGYN field in general loves these algorithms, and it makes sense, but this is all we just described. Review this and see if it makes sense in the context of what we just discussed. And as I mentioned, ectopic pregnancy will be discussed in a separate discussion. But to put it simply, if there's evidence of if you have an intrauterine, if you have a positive pregnancy test and there is vaginal bleeding and abdominal pain, and you do an ultrasound and there's nothing identified in the uterine cavity, and there's some adnexal mass, meaning that there's a presence of something that looks like a cyst or a tissue otherwise should not be present outside of the uterus, then that would raise your suspicion initially, and then there's a whole discussion about ectopic pregnancy. But when we move into the second and third trimester, there are different clinical scenarios which are associated with bleeding. Um, in general, when you go beyond to 14 weeks to at 27 and 6, which is your second trimester, and then your third trimester is 28 weeks and beyond, bleeding is less common. So when you encounter bleeding, especially in the second trimester, you have to understand, you have to do a very thorough evaluation of what's going on. A very common reason for especially spotting or light bleeding in the second trimester is due to sexual activity during pregnancy. The cervix, as pregnancy continues, becomes highly vascular, and it's very delicate as a result. Okay, so any sort of activity or pressure at the cervix is going to cause some spotting. So a very common complaint that you'll see in the obstetrical triage area is a patient comes in the second trimester and complains of spotting, right? And a part of that history that's very important because of what I just mentioned is to ask for recent sexual history. Now, that's something that is not a routine question in the third or really the first trimester because it's not a concern. Here, you want to ask that, and that may not be terribly obvious because it doesn't really describe that anywhere else, but that is something that's anecdotally and clinically something that's very common, and that's based upon the physiological changes of the cervix. But I feel like that has a name. I think it's Chadwick sign. I'll have to look that up and follow up with you. In terms of the actual, like the physiological changes in labor of the cervix, it makes it look a little blue because it's hypervascular and more than just arterial. It has the venous drainage that, because veins are more, they are less muscular in terms of their strength. They can become swollen and dilated and make the cervix appear blue. But anyway, sometimes I ask that. It's more like a step one thing, and then your third trimester, as I said. So at these times, you want to think of early pregnancy, loss, and miscarriages, as I mentioned, because by definition it's before 20 weeks. But really, this is when we discuss things like placenta previa, placental abruption, and then other things like uterine rupture and vasoprevia. So placenta previa, all of these we'll discuss in detail, but to mention them first, so you can get them straight in your mind, a placenta previa occurs when the placenta implants over the cervical os, which causes bleeding to escape through the cervical opening. What's important to know is that this bleeding is usually painless because it's not related to anything wrong with the uterus per se. It's just that it's essentially leaking because it's in the wrong spot. That is in sharp contrast to placental abruption, called abruptio placentae, is where there's premature separation of the placenta from the decidua where it implants. So that causes pain and bleeding and has a consequence to the fetus because now its nutritional supply is being compromised, one, and two, remember when I told you the uterus can accommodate a pregnancy or push something out. The fact that the uterus feels the presence of the placenta separating, it then has something can happen that it's called a tetanic contraction, and that the uterus just clamps and tries to essentially push out that the part of the placenta because it's hanging down. That's a signal that it receives. So you have contractions and very strong and consistent contractions that will lead to pain, and is part of how you diagnose placental abruption, which is a clinical diagnosis, as opposed to placenta previa as done on imaging. And we'll describe those in detail as well. Uterine rupture is in the context of a patient who's laboring, so an intrapartum patient. um, where you have a previous cesarean delivery, so the uterus has a scar on it. If if that uterus begins to contract, it can happen that that scar opens, and then that's when the uterus ruptures, and that can have consequences that cause bleeding. But that is what you really want to remember for uterine rupture. But in the context of what can occur, uterine rupture does not necessarily have to occur with a previous uterine incision. So, what unscarred uterus, it can happen that the uterus can still rupture, and I'll get into the nuances of that as when we discuss uterine rupture. But to not confuse yourself, it's especially for your examinations, the uterine rupture will occur in the context of a previous uterine uh, incision, usually a cesarean delivery incision. And then vasoprevia. Vasoprevia is when the fetal blood vessels. So when you think previa, you want to think of something that's overlying the cervical os. So vasoprevia is when the fetal blood vessels are, one, not encased in the umbilical cord as they should, so they're exposed, and two, they are overlying the cervical os as well. So this is a very high risk situation, because if those delicate vessels are disrupted, the fetus can hemorrhage and exsanguinate, which is not a terrible amount of bleeding, but for the fetus, it's enough to cause acute blood loss and leads to a fetal demise. Usually, if this is encountered in a question for you guys, it'll have a discussion that you had a mother presents and she has maybe decreased fetal movement, and she had a documented pregnancy prior. She has a history of bleeding at home, vaginal bleeding, and then when you evaluate her, you can't get a fetal heart tone. And because she had those, and if they don't mention that this was known, uh, the idea is that she had a vasoprevia, those vessels ruptured, she had bleeding, and now there's a fetal demise. Okay, this is very rare, but it is something obviously if you do training in OBGYN, you'll encounter. This is actually vasoprevia is one of the few indications for bed rest at in the third trimester. Okay, bed rest is generally never the answer, because prolonged immobility in the context of pregnancy most readily leads to deep vein thrombosis due to that pregnancy is a hypercoagulable state as well, and immobility in general. But that's also something that's very important to know. Because the management of vasoprevia is very controversial, it's not usually going to be asked about on your examinations. What they will expect you to know is what it is, one, and two, how you may determine that this has occurred in the way that I've described. Okay? So understand, at least at this point in your lecture, what these things, these clinical scenarios are, and that'll help you distinguish them from each other. But more than that, we're going to discuss them in detail. Okay, so just going to pause here because our recording times out every 50 minutes. Discussion about second and third trimester bleeding, about placenta previa, abruption placentae, placental abruption, as it's referred to, uterine rupture, and vasoprevia. So let's get into them a bit more specifically. Here's a visual way to understand these things. A placental abruption, which placental abruption and abruptio placentae are used interchangeably. It's when there's premature separation of the placenta from the uterine wall. Now, the uterine wall being the decidua, which we'll get into our discussion about placenta accreta. A normally implanted placenta will be on that interface. It shouldn't be in the myometrium, say example, myometrium being the uterine muscle wall. This is associated, placental abruption is associated on the fetal heart rate, say, with late decelerations. Those are, in the context of vaginal bleeding and late decelerations, you want to have this on your radar. Now, placenta previa, on the other hand, is when you have the placenta is implanted otherwise normally in the decidual interface of the uterus, but now it's right over the os, so there's leakage here of blood. Ordinarily, that in of itself is not a terrible problem, but what is a problem is that when mom goes into her labor, when you start into normal labor, if you start to contract with a placenta previa, your hemorrhage will be profound. And truly, if you've ever seen this, it's actually very scary, for lack of a more sophisticated explanation. I remember when I was a resident, we had a patient who went into preterm labor at 33 weeks, and she had twins and a complete placenta previa, and she hemorrhaged. By the time we even saw her in the ER, she had hemorrhaged 2 liters. She had bled at home. She needed an emergent cesarean delivery, and she had to be stabilized in the ICU for a couple weeks, so because the hemorrhage was so profound. So it's a very serious thing because of the fact that can lead to a profound hemorrhage when uterine contractions begin. Otherwise, the presence of a placenta previa, you'll have some bleeding as a result of leaking through the cervix, but that only is an indicator of what is going on. That's not really a threat to the fetus or the maternal well-being. So that's why placenta previa matters. Okay. So moving on with placental abruption. Risk factors include if you've had a prior placental abruption, but also in trauma, or so when you have abdominal trauma, either by a fall or a motor vehicle accident or an altercation, this can cause the placenta to be knocked off, in a common way to put it. That can lead to a placental abruption. But any disorders that impair the vasculature are also going to increase your risk of abruption placenta, and that's how you want to categorize it in your mind. So, from that same concept, you have smoking impairs. You need it. In adults, prolonged smoking can lead to peripheral vascular disease. Cocaine use, and not necessarily ongoing cocaine use. Even a history of occasional cocaine use can cause this, because that does modify the vasculature. And then, of course, hypertension. Usually these things kind of can go together. Hypertensive disorders, cocaine use, smoking, they all kind of affect each other in terms of cause, ultimately, hypertension and these vascular insults. Something also important to mention is that in the context of what you'll see as preterm, pre-labor rupture of membranes, in that when you have before 34 weeks gestational age, if you have a breakage of your amniotic sac, which is called pre-labor rupture of membranes, in the absence of preterm labor, by definition, because it's pre-labor, those patients are admitted to the hospital, and you watch them. You manage them in a way that I'll describe in a subsequent lecture. But what ultimately causes those patients to go into is to deliver, or to have a situation where delivery is required. That is because of usually is because of placental abruption or intrapartum intrauterine infection or inflammation, triple I, or what's was referred to previously as chorioamnionitis. So infection, basically. Placental abruption is what causes those patients to deliver. So you also want to keep that on your radar when you have patients with preterm pre-labor rupture of membranes, short PPROM, admitted to the hospital. And also if you have a clinical scenario that you're presented with on a question bank and they talk about this, and then you have a patient admitted with PPROM, and then there's a sudden change in fetal status and delivery is required, like what happened? It's this. A placental abruption is what occurred. Okay? So moving on with the findings, first of all, placental abruption is defined clinically. Okay, there's no while there's a role for imaging via ultrasound, it's a clinical diagnosis at its heart, and that's because it presents with vaginal bleeding, uterine tenderness, and uterine contractions. Now, it says with or without a non-reassuring fetal testing. You can have a placental abruption occurring, but that doesn't necessarily mean that the fetus will be prolonged fetal distress. Really, if you look at this picture, it depends on the extent of the placental abruption. Sometimes the placental abruption can come completely off, as in complete placental abruption. The whole placenta separates. You will most certainly see a non-reassuring fetal status, and that's an emergency that requires emergent cesarean delivery, and that can result in a fetal death on that result. If you have only a part of it that separates, for example, you'll have bleeding. And what you'll actually see on the fetal heart rate is tachysystole will often develop. You'll have a development where you see something like this happen. The patient will complain of vaginal bleeding. You'll see a contraction every minute or so, but you may see just an otherwise normal fetal heart rate, right? And sometimes we make a joke when we're dealing with a laboring patient who is having a small placental abruption. We'll say, oh, this is great, because what'll happen is that because the uterine contractions increase because of the same principle that I already described, that the uterus is trying to essentially push out the placenta because it thinks it's something abnormal, that increases the uterine activity without the need for augmentation agents, and actually that makes your labor progress faster. Okay. And then what you'll see is when you ultimately deliver that patient, once the fetus is delivered, the placenta quickly follows. That's third stage, which can normally be up to about 30 minutes. Actually, it's near immediate, so that's also a way that But from a fetal context, your fetal heart rate remains fine. So that's why it says with or without a non-reassuring testing, but you can be sure that with a larger separation of the placenta or a complete separation, it does carry a risk of fetal risk, or also it can cause more profound bleeding, which can then lead sometimes to the extravasation of the blood into the myometrium, and you have something called a Cavoliere uterus. I am not someone who ever studied French at any level of my life, so there's probably a better way to say that. But what you see is actually something, the blood will seep into the uterine wall, and that's quite painful. That's not very common, though. You don't really see that. Usually what you'll see in a placental abruption, that when the placenta is delivered, you'll see hemorrhage on the surface that actually separated, okay? So you can appreciate from this image is that the smooth surface is the part that remained intact. This here was the site of ongoing bleeding, and you'll see it like a hemorrhage like this. This is a very clear example, but you'll see this is something that you do actually see in terms of you have this kind of swollen clot presentation on the surface that was that had been expelled, and then the smooth surface in that which had remained attached to the wall. This can also be confirmed when you send your placenta for histological evaluation to the pathology department. They'll tell you the presence of areas of hemorrhage versus not, and that will also confirm your diagnosis as well. In terms of other things that are involved in the diagnosis of a placental abruption, oftentimes you will do an ultrasound. Um, you sometimes can identify a retroplacental hematoma or a blood clot on imaging, for example, and that will give you an indication to say that you do have a placental abruption brewing. However, that's not always found. So because it's not found, that doesn't mean that it's not there or happening. It's just that it's a limitation of the imaging. So that's why, while imaging can support your diagnosis, it's not a radiological diagnosis. And furthermore, okay, so let's pick it up. We were mentioning in our fibrinogen, the fibrinogen level will be low. For example, in pregnancy, fibrinogen is actually part of the coagulation cascade that's actually elevated. So it sometimes could be in the 600s or so. When you have hypofibrinogenemia, it's usually something about 250 or less, and that can give that's it a part of the criteria for say a stage 2 or 3. But this is all kind of that sort of discussion is after the fact. So you can't use it in real time to determine if there's a placental abruption or not. So while there is a classification, it's not anything that's used clinically because it doesn't have the utility in a real-time application, and it's also something that they're not going to test you on. But if you come across it, at least be aware that it exists, okay? So that's placental abruption. And review that information. That's pretty high yield, both clinically and on your examinations. In our population at St. John's Episcopal Hospital, our patients are primary Black race women, and as a result of that, they have a increased risk for hypertensive disorders in general, in addition to hypertensive disorders of pregnancy. And then because our population is high risk, oftentimes there's drug use and smoking as well. So placental abruption is something that we actually encounter quite a bit. So you'll certainly see it. And more than that, you'll understand the nuances of something that's a catastrophic one versus one that's can be managed in a way that's not much of a threat to the maternal and fetal well-being. Okay, so we're going to move on to placenta previa. Placenta previa should be suspected in any woman who presents with vaginal bleeding in the second half of her pregnancy, or second trimester is what should be better said. Second trimester onward. Most often in routine prenatal care, a patient would have received an ultrasound in the first trimester to associate for fetal viability, as well as that's when genetic testing is initiated with nuchal translucency, and the genetic and the biochemical markers that are drawn in the first trimester. Okay, at that point, a placenta previa is not really a concept. The next time, as in it's not, the placenta is usually just developing, and really it's not anterior or posterior. It's just kind of all around. When you get the next time for routine evaluation, you'll have an ultrasound around 20 weeks is when the fetal anatomy is performed. All the parts of the fetus are looked at by a maternal fetal medicine specialist, and they're looking for things like neural tube defects and appropriate fetal growth, etc. The placenta, you can start to maybe consider if you have a placenta previa or not, okay? But the important thing to know, at least in this juncture, is that while you may identify a placenta previa at say 20 weeks gestational age. The placenta moves throughout pregnancy, and that's something that's a little hard to understand. You would think we say the placenta implants, right? Usually when things implant and they stay there, kind of like the fetus. If you have an ectopic pregnancy that implants in the fallopian tube, it's not moving, you can't move it, all right? Or at least we haven't figured out how to do that right now. But the placenta is very different, and it's a very interesting and sophisticated sort of organ in that it shifts throughout the pregnancy, and that's not theoretical. It's known anecdotally, and actually, in terms of its being studied, I believe that that they actually had done studies about to verify that in sort of like a basic science context. There's actually a medical journal called Placenta, which I actually want to look into a bit more for that study I'm mentioning, and we could discuss it when you're on your clinicals here, your clinical modules. But so then that just requires follow-up to see if you have in the third trimester, if you have a placenta previa, then it's most likely not going to resolve it. And that's just a practical consideration. But if you have vaginal bleeding, you want to make sure that this is not the case. So if you have a patient who comes to labor and delivery and she's in her second trimester and she's having vaginal bleeding, oftentimes we'll try to get any records available, but also the placenta can move. So what you'll first do is a speculum examination to look at the cervix and to ensure that there's not any bleeding. You don't do it, say, a sterile vaginal exam at that point because you're not entirely sure if you have a placenta previa. If you're doing a vaginal exam and then you're digitally disrupting the placental interface at the cervical os that may be there because of placenta previa, you're going to cause bleeding, and that's going to make things worse, okay? So then you do, after your speculum examination, you do a transvaginal ultrasound. There you can find your cervical length, and then you can also determine if you have a placenta that is abnormally covering the cervix, which is called a placenta previa. The absence of abdominal pain and uterine contractions, as I mentioned, is considered a clinical feature that can distinguish between placental previa and placental abruption. They say classically because that's not 100%, but anecdotally, I'll tell you it's something that's pretty reliable, okay? ACOG most especially doesn't want to commit to one thing over another unless it's really 100%, because that's their recommendation as a society. But certainly for your examinations and quite reliably in the real clinical scenario, this is something you want to use to distinguish a placental abruption from a placenta previa in terms of bleeding. So there's two terminologies that exist in modern practice. There is something called a low-lying placenta, which is not completely over the os itself, but it's close. It's within a close margin here. Or you have a complete placenta previa, which is categorically, the mass of it is over the cervical os, okay? A normal placenta can be first of all, it's away from the cervix, but the way that these things are described is either anterior or posterior. This is a not quite the correct view to demonstrate that, but if you have it on the back, if the placenta is implanted on the back of the uterus, for example, in the posterior part, that's when it's determined to be posterior. And on your ultrasound, really, it looks like this. If you kind of have a view where your ultrasound is showing you the anterior surface and the posterior surface of the uterus, and you're getting almost like you cut it in half. If your placental mass is up here, well, that means it's anterior. If it's over here, it means it's posterior. And then generally, it's not quite so delineated. You'll have something that looks like this. If it's posterior, and then anterior can kind of hang out there. If it's all the way at the fundus, then you call it fundal, okay? That's just a practical consideration. But that's placenta previa, okay? A lot of times placental previas you'll also get an MRI So this is one of the indications where you'll actually use an MRI in obstetrics. Generally, MRIs are not used. Usually, ultrasound is all you need. MRIs are used for two purposes, really. One is because when you have placenta previa, which, if you can see, depending on the resolution of your screen, this is the placenta, and this is a sagittal view. Okay, so this here is your cervix. You want to be familiar, your uterus proper is here. You want to be fairly familiar with sagittal views because it highlights anatomy for you. This is the cervix. Your bladder is anterior to your uterus, right? So your uterus is here, anterior. This is anterior. This is posterior. Posterior, of course, because you have your spine, right? Everybody knows the spine is in the back. So your bladder is anterior, and then your colon is here. Okay, so when you're looking at these things, that's how you know. Colon's posterior, and bladder's anterior, and this is your thing. But you see this the placenta, and it overlies the cervix. So this is a complete placenta previa. But the reason why we get MRIs, which is what I started to say and I interrupted myself, is one, because if you have a complete previa, you have a higher risk of something called a placenta accreta. Okay, and a placenta accreta is when it's called now placenta accreta spectrum. You may have heard older terminology that says morbidly adherent placenta, but basically it's when the placenta itself invades into beyond the decidua and it invades into the myometrium, but it can go as far as through the uterus, even into the bladder, and we'll talk about that next. But the way to figure out if that's happening is determined by an MRI, and that's why you get an MRI in cases of placenta previa. You can always tell there's a previa on ultrasound. That's not really a difficult diagnosis, but the placenta accreta is harder. Okay, and then two, patients who have a suspicion of appendicitis in pregnancy, um, usually general surgery will want you to get an MRI. You can do a CT scan in pregnancy. There's a certain level of radiation that is acceptable for the fetus in terms of well-being and development, and a CT scan is one of those. But an MRI is generally preferred because there's no radiation. And ultrasound, while you can do an ultrasound, it's harder to identify the appendix on ultrasound because it displaces the appendix in the right upper quadrant, and also it's hard to see the views as well. In terms of, while I mentioned it, for medical imaging via CT scan, really the only CT scan that's most readily used in the context of an ongoing pregnancy is if you're trying to rule out a pulmonary embolism. And that's where you do a spiral CT or CT angiogram. Okay. And that's something that's unequivocally accepted as a CT scan that could be used in pregnancy for that purpose. Okay. But to move on, placenta accreta spectrum is generally when you have a placenta that attaches too deeply into the uterine structures, starting with the uterine wall and beyond. A normal pregnancy, it attaches to a temporary layer in the uterus that sheds. So that's your decidual layer here. And if you could appreciate in this picture, you see this thin line, right? A placenta accreta happens, it's called spectrum because there's three different entities. The accreta happens when you go too deeply into the uterine wall, okay? So a little anatomy, there's the uterine wall, and then you get into the myometrium itself. So this is the endometrium, is what you want to think of as uterine wall in this context. So it shouldn't invade into the endometrium, okay? Because the endometrium is something that remains. There's always endometrium in the uterine structure. The decidual layer is the one that kind of is sloughed. So when that happens, you have a placenta accreta, and it's not going to separate on its own, and that's the point. Normal delivery, the interface will this temporary layer in the residual, this will shed and the placenta will come off. It'll get the signals to do so. Not so with placental accreta. In addition, your increta is when it goes into the uterine muscle itself, and then a percreta is actually when it goes through the vessel, and it can even invade the bladder, which is quite profound. So, a highly interesting clinical scenario in that, first of all, why the placenta would do that in the first place. Risk factors and things like that are pretty unreliable, with the exception of one, which is your uterine incision. The I'm sorry. Your uterine incision, the presence of uh, a prior uterine incision, and as that goes up, in addition to a placenta previa, greatly increase your risk. Okay, just gonna get some water. Okay. So to put it specifically, if you have if you have a if you have a previa, a complete previa usually, plus a cesarean delivery, that's very different than if you simply have a cesarean delivery in terms of your risk. So if you have a placenta previa and you have a primary cesarean delivery, as in you only have one, your risk is 3%. If you have a previa and your primary cesarean delivery. If you don't have a previa, it's actually 0. It's 0.03%. Quite different, right? Moving on, if you have a secondary, now you're at 11% with a previa and a cesarean delivery. Here, you're only at 0.2%. You haven't even made 1% yet. And then onward, it goes to 40% at your third cesarean delivery. And then you have 61% at your fourth, and then 67% after five or more. For simply having a cesarean delivery otherwise, you're just at 0.1% at your third, and then at your fourth, you have 0.8%. And you really only make it to pass 1%, 4.7. So what I'll do is when I revise the slide deck, I'll actually include these numbers here because they are important to know. But that's a very different story if you have a previa and a C-section versus just a cesarean delivery is the point, okay? Your risk increases quite a bit. So when you're looking at questions, or even if you have a patient, if she has a complete previa, that's why we do MRIs, because we're like, all right, if you have a previa, and you've had, especially if you had a prior section, you really need to know this because this risk is high. So this is a patient that I actually had at the tail end of my residency, okay? This patient actually had one prior section, so it was her secondary cesarean delivery, okay? So she had a secondary CS, but she had a complete previa. She had an ultrasound done that actually ruled her out for placenta accreta, okay? But as I said, imaging is not, she never had an MRI. I think she didn't follow up, but The point is that her risk here for a placenta accreta is 11%. She ended up having bleeding. The way that it works with placenta previa and bleeding is that you basically give them 3 chances, and if they have another bleeding episode after that, they get admitted to the hospital for observation, and if they have a fourth bleeding episode, they get delivered. Okay. So this patient, she had her fourth bleeding episode. She was about 34 weeks. So we took her for a cesarean delivery. And what we found when we went to go remove the placenta, and I hope that you could see this probably when you look at the slide deck. What I'm doing is I'm clamping this and putting it on tension to demonstrate that the placenta would not come out. And more than that, let me use a different color because. So this is the endometrium, and this is where the placenta is, okay? If you could tell, this thing, you could tell even with traction, it just shot down into the uterine wall. So we were like, oh boy, this is a placenta accreta at the very least. So the treatment for that, for a placenta accreta spectrum, as a standard of care, is something called a cesarean hysterectomy, which is a term for hysterectomy at time of delivery by a C-section, and that's what we did. Even it was unplanned, but that's what happened. So this risk wasn't terribly high, but it was always on the back of your mind, because if you have a complete previa and a prior cesarean delivery, this is a risk, and that's the bottom line. Okay. So to move on, we're going to discuss. I'm sorry, I'm trying to pull this up. Okay, so we're going to discuss uterine rupture. Okay, so like I mentioned, a uterine rupture is in the context of, most commonly in a context of an intrapartum patient. Intrapartum being that she's in labor, usually in the context of a term pregnancy, or at least early term, right? So the incidence of a uterine rupture is something that depends on the type of cesarean delivery that was performed, right? So what's determined to be defined as a classical cesarean delivery, or a hysterotomy, which is a hole in the uterus, is where you had your uterine muscle, and they would do a cut down the middle through the myometrium, through the uterine muscle to deliver the baby. As time went on, in clinical practice, they determined, they said, hey, well, the lower segment here that develops is more avascular because it's thin, it's less vascular, I should say. So maybe we should deliver through there instead. It's less vascular because what happens is that as the uterus develops and becomes gravid, the strong muscle part that has to contract remains up here, and then it kind of thins out before it leads into the cervix. Okay, this thin area gives an opportunity to do your incision without a terrible amount of bleeding. And also because the uterus will contract down like this, right? From the fundus down. So that puts stress on your incision point. Here, that's less of a concern, though it always is a concern. So when you have low transverse uterine incisions, your risk of uterine rupture is less than, say, your classical uterine incisions, or even vertical ones that go up here. So in the most recent study available by the National Institute of Health and the Maternal Fetal Medicine U Network in 2004, they determined that the uterine rupture rate was about 1.9% if you had a prior classical inverted T or J. An inverted T looks like an inverted T. Sometimes what you'll have to do is you have a low transverse, but then you have to extend it, so it ends up looking like a T to get the fetus out. Or and a J incision, what ends up happening is when you have scarring that's so bad that this part of the uterus, say, is like plastered to the anterior abdominal wall. It's so strongly adhesed you can't separate it. You end up doing something like this to get the fetus out, so it looks like a J. Okay. Even so, that's only 1.9%. If you round that up to 2, that means 98% of the time you're all right. In a low transverse uterine incision, it's 0.7%. So that's less than 1%, which means 99% of the time you're fine. But the reason why we care is because if your uterine rupture occurs, the consequences are very severe. Okay? This invariably can lead to fetal death. This can lead to just profound rupture of the uterine vasculature, especially the venous supply or the broad ligament. And if that all of those vasculature are compromised, that can lead to hemorrhage, that can lead to a maternal death. Okay, so and anecdotally, as rare as this seems to have been from this study, you also got to understand the context of these studies too. This was a multi-center, national, what have you. But say in our population, our high-risk population, or even just New York City in general, their population, your inner-city population, we've seen plenty of uterine ruptures to the point where the percentage is not 0.7%, okay? It's way higher than that. So you obviously got to know your population and what you're dealing with, but at the same time, this risk is not super high, but it's something that is encountered, so you have to be ready for it. When you have a disruption of your if you have a uterine rupture in the context of a prior cesarean delivery, usually in the lower segment, like I mentioned, the fetus can be extruded here, but also this this rupture, because it is a rupture, right? It's not just like a slow tear or whatever. It can be. That's more referred to as a dehiscence. But a rupture then can disrupt your primary vasculature. That can cause a lot of bleeding, not to mention all of the blood vessels in the broad ligament. When you're on your clinical modules and the uterus is exteriorized, you look at the broad ligament, it is just swollen with these like gargantuan veins. You can imagine if they rupture, it's a bad situation. This is an interesting image that I had found. This is in the New England Journal of Medicine, which is a highly regarded medical journal. And essentially, the story of this woman was that she was 28 weeks gestational age. She was complaining of this vague pain that they did an ultrasound, everything looked okay. They couldn't really tell what was going on. The provider ordered an MRI, and what you actually see here is that you have a uterine rupture occurred where the scar had opened, right? So this is the uterus here, and the part of the scar, this is intact, but this part opened. So the fetus's legs and the amniotic sac, which is here called an amniocele, when this happens, amniocele, that was the case. So she was having this pain. This is a uterine rupture that occurred, and this occurred at 28 weeks, which is just the threshold of your third trimester. At the beginning, I should say. And then what ended up happening, they recommended delivery, really, and the patient refused, so they gave 2 courses of they gave a full course of betamethasone, and then at 30 weeks, if you read the report, which I have a link to, the abdomen here was actually in this mass. So they were like, the providers had recommended that she have a cesarean delivery on that basis, and because she had her corticosteroids on board and they were prepared, she had a cesarean delivery at 30 weeks, and the fetus did fine. So uterine rupture is usually most commonly seen with more severe consequences in the context of the third trimester, but everything in obstetrics, rare and interesting things can happen. In addition, I also mentioned that a uterine rupture can occur in the context of an unscarred uterus, and that is true. And that's something for what it's worth I have actually seen in the course of my residency. But what ends up happening is that the rupture looks kind of like this. There's no this is the front of it, the anterior surface. So there's no scar here, right? So what ends up happening is you have something that kind of will be on the back of the uterus. It looks like a burst. So this is the posterior surface, okay? Looks kind of like that. Like if it kind of got punched out. It's a muscle, it could rupture. So that's why when we had a discussion about labor management, that's why you don't give oxytocin and misoprostol together. Not only for the fetal distress due to secondary tachysystole, but also because things like this were happening. Okay. All right. And then the last part of our discussion revolves around, in terms of obstetric hemorrhage, is postpartum hemorrhage. So if you can appreciate, what we discussed thus far is you have your first trimester. So that's 0 to 13 and 6. Okay. This is where you're going to have your miscarriages. Okay. And ectopic pregnancy. Your second and third, you're worried about things like placental problems, right? So placental abruption, placental previa, then placenta accreta spectrum if it comes to that. Intrapartum, meaning that intrapartum, okay, so let's just say this is 28 to like 36 and 6, right? While uterine rupture can occur in the preterm period if you go into preterm labor, intrapartum, you want to think of uterine rupture. Placental abruption, because as you're laboring, you can have a placental abruption occur. When we discussed it in the terms of the second or the third trimester with placental abruption, that's something that where that occurs and then it leads to problems. This is like you're laboring and then the placental abruption occurs, which is a thing. Okay. And that's primarily your obstetric risks of obstetric hemorrhage when it comes to your intrapartum patient. And now, the last part of this discussion is your postpartum patient, right? So your third stage of labor. This is your first and second stage of labor. Now your third stage of labor. All right. So once you deliver that placenta, that's when you can have a postpartum hemorrhage. And then there's a bunch of reasons why you can have a postpartum hemorrhage, which we'll get into. Okay. So this is the bulk of what you need to know regarding obstetric hemorrhage. And this is an extremely high yield discussion, both clinically and for your examinations. So focus on this most readily. This also is a way that you're going to synthesize when we discussed your fetal heart rate tracings, when we the intrapartum fetal heart rate monitoring, all of that, and in addition to your labor management strategies and your principles of labor mechanics. All of these have to do with that. And this is sort of the culmination of it all. So those three lectures all relate to each other. Having a good understanding of that is what you're really going to help you for your examinations in obstetrics and gynecology, and those who are interested in obstetrics and gynecology. This is, if you know this stuff as an intern, you're just going to be an absolute rock star, um, and beyond. So a postpartum hemorrhage, it's important to understand the definition of what a postpartum hemorrhage is, okay? So ACOG, in their Revitalize program, because and just so you know, in OBGYN, they love sort of these acronym sort of terms. If you're ever trying to do anything, if you come up with a great acronym, like you're really gonna make waves. I know that here at St. John's Episcopal Hospital, we had in 2020 we submitted 4 things that got presented and accepted and presented as posters for the Society of Maternal Fetal Medicine's pregnancy meeting, which is a good meeting. And one of the studies, it was an osteopathic study, but that we had done, and I had organized the title to be the labor study, the LABOR study, which I said was labor. What was it? Labor. It's like labor length and birth outcomes, osteopathic research. Yeah. So, and they love that. So, just FYI for those researchers out there. So, anyway, a postpartum hemorrhage defined by ACOG is cumulative blood loss greater than or equal to 1,000 mLs or accompanied with signs of symptoms of hypovolemia within the first 24 hours after the birthing process, regardless of route of delivery. Traditionally, a postpartum hemorrhage was a term defined as 500 mLs of blood loss or more on a vaginal delivery, and 1,000 at time of cesarean delivery, okay? And while that terminology still remains in terms of identifying if there's an abnormality or not, like if you have more than 500 ml blood loss on a vaginal delivery, well, that's more than normal, right? But in terms of defining postpartum hemorrhage, it's 1,000 or more, regardless of route of delivery. This is of blood loss. And it's also accompanied by signs and symptoms of hypovolemia, okay? Generally, postpartum hemorrhages are not hard to find, right? You know it's happening or it's occurring, but definitions are important to know. Right. So your differential diagnosis is divided into these 4 T's. Again, not much of a fan of mnemonics, but these actually come from ACOG, and they are helpful. So the first and probably the most important one is abnormal uterine tone, which is referred to as uterine atony or an atonic uterus, okay? That's often confused with postpartum hemorrhage, right? So you have a patient, she delivered and she had abnormal tone called uterine atony. There was heavier bleeding than normal, and they said, oh, there was a postpartum hemorrhage, and we gave uterotonics, etc. Not really the definition of postpartum hemorrhage, but it is a leading cause of postpartum hemorrhage, 70 to 80%. Okay, and it usually should be suspected as the first etiology of postpartum hemorrhage. Now, remember let me skip to this. Remember when I mentioned to you that the uterus has the 2 jobs, to accommodate a pregnancy and to contract and push out something, a foreign, well, not, I shouldn't say foreign, something that shouldn't belong in the uterine activity, uterine cavity. Well, these arteries here, the blood supply to the uterus, they're like these spiral arteries, okay? They go in a spiral pattern, and the reason why they do that is because they're coiled ordinarily when the uterus is non-gravid or small. As it grows, they uncoil so they can move with the uterus, which is actually pretty elegant. But what's important to know is that after the uterus, after the placenta delivers, um, the uterine muscle is supposed to contract down, okay? And that contraction, it will compress the way that these blood vessels feed into the uterine wall, and that'll stop the bleeding, okay? And more than that, as the uterus begins to contract, it even kinks off these spiral arteries here, okay? If that doesn't happen, then bleeding just keeps free flowing, okay? And that is a cause of acute bleeding because nothing's stopping it, okay? And that's because the tone of the uterus is abnormal. When we spoke about our labor management in that lecture, I mentioned to you that oxytocin is a universal medicine. I mean, it's a medicine that's applied as in the postpartum period globally for the purpose of prevention of postpartum hemorrhage, and it's for that reason, to ensure that this tone is restored. In normal pregnancy physiology, that tone should be restored, right? To encourage that, even in addition to intravenous oxytocin, you have uterine massage by manual compression, which is, I have an image of it, but basically that's why when you see in your clinical modules, when mom delivers, you'll see the delivering practitioner who will be rubbing on, it appear that they're putting a firm massage on the patient's abdomen, but it's not the abdomen they're doing it to stimulate the uterus to contract. And then also a bimanual compression is when you basically do that, like sandwich the uterus from both sides, internal and external, to encourage that. And then there are medicines and things you can use if that's not occurring, which is what we'll talk about in terms of medicines called uterotonic medicines, uterus tonic contraction, as a means of treating uterine atony in the context of postpartum hemorrhage. Additionally, postpartum hemorrhage can be caused not just because of uterine tone, but because of trauma as well. So genital tract lacerations, for example, expanding hematomas or uterine rupture, those can occur in the context of otherwise normal uterine tone. The uterus can be contracting well and everything else, but if you had a delivery where there was extensive vaginal wall lacerations and you had bleeding that amounted to 1,000 mLs or more, or just that associated with signs of hypovolemia, then that is still a postpartum hemorrhage, and that's why it's distinguished uniquely from an atonic uterus. Expanding hematomas, I'll describe in a little bit, but basically what ends up happening is that there's damage to the vasculature, either on the external or internal surface, which causes ongoing bleeding. Now, if you just have a hematoma that's not expanding, eventually it will tamponade itself off and stop, and that's blood loss that you have to account for, but it's not an ongoing concern. Expanding means that the blood loss is continuing, and I'll skip to it briefly. Depending on your compartments, this makes a difference. So if you have your what's called like your intralevator sort of bleeding, if you can appreciate from this image, yeah, you have bleeding, but this continues. And this space, these fascial compartments can accommodate, which means that it won't necessarily tamponade itself off. So if you notice that you have, and you'll see a hematoma here, right? It's not bleeding out yet because you haven't released it. So if this bleeding continues based upon whatever vascular structure was ruptured here, usually branches of the pudendal artery, internal pudendal artery, this bleeding will continue and go, and you may not see it. So one, you have to recognize it, which is simply done by monitoring maternal vital signs and also literally of seeing if the thing's gotten bigger. You could trace it. And two, if that's the case, you have to control this bleeding. And we'll describe how you do that as we go on in this discussion. This is an example of where it's like outside of that levator space, but it's less concerning because this has nowhere to go, essentially. So it will tamponade itself off potentially, but it can continue to expand depending on there's a potential for this to expand as well. So you would have to evacuate it and control this bleeding as well. But this is more of a risk because you won't necessarily see it and it will continue to bleed up. But also retention in terms of trauma, retention of placental tissue uh, can cause ongoing bleeding even in the presence of normal tone. But this is usually what occurs in the context of secondary postpartum hemorrhage, meaning that the patient will go home and then continue to bleed, and then so it'll come to the ER and you'll do an ultrasound and you'll see that there's retained tissue. Sometimes there's placental abnormalities where there's different shapes or lobes to the placenta, or maybe a part of it got sheared off and you didn't notice. That's why also you have to always inspect your placenta after it's delivered. And the treatment for this is removal of the tissue, which is most reliably done with the suction dilation and curettage, as if you would manage for a miscarriages that require surgical treatment, like a septic abortion or an incomplete abortion with hemorrhage. And some patients can elect for a suction DNC for cases of otherwise stable, like say missed abortions as well. And then if patient has a coagulation disorder, that's where thrombin comes in. This is just a chart to help you understand these etiologies, but it's really all that we mentioned. In terms of coagulation defects, we'll get into this a bit more when we talk about abnormal uterine bleeding in the context of a non-pregnant patient. But the most common thing you want to think about is von Willebrand's disease if you have ongoing bleeding, because most patients who are otherwise young and healthy, their first challenge to their coagulation system is really pregnancy. Pregnancy and dental work seems to be the most common thing. So if you are concerned about a bleeding disorder, a von Willebrand panel is something that you want to draw. It's called a ristocetin assay. We reviewed this. So the uterus normally should contract, as I mentioned. Here's a visual way to see it, and then it'll stop. If you can appreciate what'll happen is you'll have when you feel it, it's very floppy, kind of like a floppy sort of rubber bag, as opposed to this is more like a rock. And then the bleeding continues for the same purpose. This is sort of how you do your bimanual massage. Usually it's not quite a fist. This is certainly how you do it. Usually it's not a fist. Usually it ends up being kind of like an open hand, like when you sandwich the uterus. Though this, in cases of severe hemorrhage and an atonic uterus, this is what you end up doing with this fist here, depending on how big your hand is. But at that point, if you're having ongoing hemorrhage that's severe, in addition to all your other treatments, this is your bimanual massage as well. Okay, so this is another way to look at your etiologies, but the point here is this is you have risk factors associated with these things. Okay, for an abnormal uterine contraction, which is atony, sometimes it's idiopathic, meaning that we don't really know, which is fair because that's usually most of the case. But there are risk factors, say an overdistended uterus, for example. The uterus is not meant to have twins, multiple gestation, an abnormally large baby, polyhydramnios. It's like if you overdistend an otherwise elastic bag, at some point it's not going to contract back, right? So overdistension of the uterus is a reason why you may have an atonic uterus, so you want to keep it on your mind. Having fibroids is actually a very big risk factor. Now, how big? If you have one, Okay, but sometimes you have women who have multiple fibroids, and it's the way that you want to think about it is if you're trying to squish a rubber bag that has a bunch of marbles in it, it's not going to happen, right? You'll have an ineffective sort of contraction because every time the uterine muscle tries to contract, it's distributing that force to these fibroids essentially. So there's no concerted effort for contraction. So in terms of just having abnormal tone in and of itself, prolonged use of oxytocin, we mentioned that for augmentation of labor, oxytocin is your only go-to, right? So if the patient needs a prolonged course of oxytocin in order to deliver, when the uterus goes to contract after the fact of the delivery, it just, even if you give a bolus of oxytocin, those receptors are saturated, they no longer function. So you have to do other things to help. Oftentimes, even just by manual massage is enough, but there are other things you can do, which we'll describe. Chorioamnionitis, which these days is called triple I, um, that can cause an atonic uterus. And the way to think about this is to imagine that the uterus is an immune response. So then when you go to contract after you deliver, the uterus sometimes has a hard time doing so. It has a hard time doing so because of the reason why it's essentially just swollen. And then general anesthesia, if a patient requires general anesthesia, usually in the context of an emergent cesarean delivery, um, that that relaxation that occurs systemically also happens with the uterus. And then hyparity, when you get into your multiparous patients, after a while the uterus is just and it's overworn, it's tired, right? But this is not always a guarantee. There's plenty of women who have hyparity and have perfect tone. Genital tract trauma is pretty self-explanatory, but operative vaginal deliveries, either by forceps or a vacuum assistance, can cause that, and also a precipitous delivery. If the delivery happens very quickly, it can cause tearing, mainly because you weren't able to protect the perineum like you usually would. But oftentimes, if a delivery is so precipitous, it usually means there's laxity for it to happen. Retained placental tissue, as I mentioned, and then uh, abnormalities of coagulation, which is quite a bit. But this is usually these are highest yield in terms of what actually occurs. We mentioned this. So how do we manage these things? This will be the last part of this discussion. Um, so first and foremost, you got to make sure that the patient is stable from the ongoing blood loss. Okay. Usually, if you have to call your medicine team in your ICU and what have you, at general surgery, in the time that this is something, if it's a ongoing hemorrhage, you need to maintain that and have massive transfusion in place for blood products and factors if that's required, especially in the context of DIC, which I'll mention briefly at the end. But in terms of options that immediately treat your atonic uterus, there are specific things. Because obviously your genital tract lacerations, you have to repair them, okay, surgically, right? If it turns out that your repairs are ineffective because the tissue is too friable and everything else, then you have to tamponade it, usually with vaginal packing, all right? Your vulvar and vaginal hematomas, you need to evacuate the hematomas surgically, drain them, and try to control your bleeding surgically in the same manner. If you're unable to do that, what can help you is interventional radiology can sometimes embolize these vessels, either the internal pudendal artery or the uterine artery itself, but those carry a risk of infertility and such, so they're generally avoided. But if you have a postpartum hemorrhage, those are options for you. But for an atonic uterus, you basically have medicines and tamponade and surgical techniques that encourage the uterus to contract, okay? Embolization of the pelvic arteries is always a case, but like I said, that is not necessarily encouraging the uterus to contract. That's just trying to blunt the blood supply, okay? So you have your medicines here, your urotonics, oxytocin, methotrexate, which is trade name Methergin, your prostaglandin F2 alpha, also called carbaprost. The trade name is Hemabate, so it has three names, or you have your good old misoprostol. All right. Um, the important things to understand about these medicines is really the adverse effects. That's what you're tested on, and we have to know this because we have to know what we can use. So, for example, oxytocin and misoprostol really don't have any contraindications, uh, but methogen and hemabate do. Okay, methogen and hemabate are both given IM. Thing you need to know for methogen is that it's contraindicated in hypertensive disorders of pregnancy or any hypertensive disorder because their side effect is hypertension. It's severe hypertension, okay? This is given IM. If you give this IV, you will most certainly precipitate a hypertensive crisis. But methogen helps you because if you're having a patient who has postpartum hemorrhage and she is having hypovolemia, usually is associated with hypotension, right? So if you're giving methogen in an attempt to restore uterine tone, it also has a slight side effect of hypertension, which helps you because it can maintain the maternal blood pressure, right? So this is really a very good first go-to medicine, and really, and anecdotally, it is. This is the first thing you reach for. You go for methogen. You only don't use methogen if you can't, and that's because of hypertension. Also, keep in mind that this is given every 2 to 4 hours. Okay, once you give methogen and you're doing your bimanual massage and things, your atonic uterus may not resolve. You can use these together, and that's the point. It's not one or the other. So, oxytocin is going to be given as a matter of routine after you deliver anyway, okay? So that IV fluid is going. Oxytocin has a structural similarity to antidiuretic hormone, so IV boluses of this can sometimes lead to hypotension and hyponatremia due to water intoxication because it will recruit the same things ADH uses. But honestly, we give a ton of oxytocin intravenously for augmentation, for postpartum hemorrhage, and like across my entire residency. I don't think I've ever seen this, but it is a thing that can happen on that physiological basis. Um, Methergin then is one option, and then your next option is carbaprost. You could start with carbaprost, which is hemabate. It can be given every 15 minutes, though, so that's also helpful for ongoing hemorrhage. Its contraindication is asthma, okay, because it can cause bronchospasm. Uh, these other things you don't really consider. It's asthma, which is a big one. And then your side effect here is bronchospasm because of asthma, right? So if you're an asthmatic, you can't give this. So if you're a hypertensive, you reach for carbaprost. But the true reason why carbaprost is not your first go-to is because of this. It causes like an explosive diarrhea and not like as a chance side effect. This is gonna happen if you use carbaprost. That's why it behooves you to give concurrently administer something like Lamodal or some sort of medicine that has atropine for the gut in it to prevent this. Now you can appreciate if you're having ongoing postpartum hemorrhage. I mean, the last thing you're thinking is to get emergency Lamodal on board, right? But it is something that happens, so you have to be prepared for it. It's like, and if you've ever seen it, it's like dramatic. It destroys the entire room, and it's terrible. But the patient's also not bleeding. So once you're given your methogen, this can be given every 15 minutes. So you kind of just keep giving this almost like a maintenance until this resolves, okay? And you're continuing to give your bimanual massage and whatever. Um, those massage techniques to restore the tone. Misoprostol, you basically give 1,000 micrograms. You can either give it orally, sublingually, or rectally. It's not vaginally here because while that makes sense for, say, cervical ripening, you're having bleeding. It's just going to flush it out. Usually it's given rectally, okay? But this absorption is delayed, right? Because it's rectal or even oral or so. The point is it's usually given rectal because one, the patient is having ongoing hemorrhage and hypovolemia, they're not going to like, you don't want to give them anything by mouth. They might asphyxiate or something. I mean, they might aspirate. So you give it rectally. So you give it, but really you're relying on these to do the work. And that's really the important part. These are the ones that you're going to continue to dose and will help you. Misoprostol will give you a low-grade fever as well. It can anyway, not necessarily. So if you give misoprostol and it's like, oh, well, they call you, they say the patient had a fever 100.7, you're not going to treat her for intraamniotic infection because right? So that medical management is ongoing, and they're all used together as you're doing your bimanual massage. If that fails, you can continue to do the administer the uterotonics but as you wait, and if you're anticipating the fact that your uterine atony is not resolving, you can use a tamponade technique as well. Now, the one that we use and that is used most generally in the Northeast, or really any um, well-resourced center, is your Bakary balloon. And it's made by Cook Medical. Bakary is the person who kind of showed it. And you can inflate it with 300 to 500 ml of saline. This is a big balloon that inflates in an attempt to tamponade off those arteries like I described already, right? This has a hole, so the bleeding then goes through a tube and you hook it up to like a urometer, which is like a Foley bag, and you'll see how much bleeding is continuing. It should slow down. If not, then you know your Bakary balloon has failed, okay? Then that's the time we have to take the patient to the OR, and you put in compression sutures to get this thing to contract down. And there's a bunch of different ways you can do that. A B-lint suture is the one that's most commonly used, where you kind of put suspenders on here, but there's something called a Heyman suture, this thing called Cho stitches, where you basically put these box stitches in to compress. This is helpful when you have lower uterine segment atony. And then there's something called an O'Leary stitch that you basically hook the uterine artery to compress it against the uterine wall to stop it. This is usually done at time of cesarean delivery, but just for you guys, just know that then surgical techniques are the point. You would have already consulted, if you have an interventional radiology at your disposal, you would consult them and they can help you with uterine artery embolization. And if all of that fails, then you go to hysterectomy and you do a cesarean hysterectomy like you would do for a placenta accreta. Now, you may need to skip some steps and go directly to a more aggressive surgical management because of something called the IC. What happens is that in the obstetric purpose, ongoing bleeding leads to a depletion of your coagulation factors, okay? DIC can happen from a bunch of different things. Say if you have sepsis, you have some sort of disorder that kicks off systemic activation of coagulation. And then this is driven by overexpression of tissue factor, and a bunch of different things, which is important to know, but the pathophysiology is not terribly important. What you need to know is that ongoing obstetric bleeding will lead to a situation where it consumes your platelets and your coagulation factors. And this is the important thing to know in the context of pregnancy. You have so much bleeding, it exhausts all of these factors, and then that leads to really ongoing bleeding. And then you'll have like this kind of like watery looking blood because there's no factors in it, right? So then your bleeding disorder has now led you into a really bad bleeding situation. These are a bunch of obstetric causes. Here's a management example. You don't need to memorize this, but it's largely supportive therapy via massive transfusion and doing what you got to do to stop the bleeding. If it turns that you've had bleeding that has already happened by the time the patient got here, you try these uterotonics for some time, but it looks like she's heading towards DIC, you would go right to hysterectomy. And then these patients have to have supportive therapy in an ICU. Once the bleeding has stopped, you have to have massive transfusion of whatever products were lost, and it's mainly supportive therapy in this way. And really, that's why we care about ongoing obstetrical bleeding, because it can lead to this, which is life-threatening, in addition to everything else we spoke about. So that's a lot, but that's comprehensive of what you need to know in terms of those first 3 lectures, in terms of your labor management and your primary clinical scenarios that require attention from an obstetrician. So review them thoroughly and always understand the the physiology on how things are happening. If you understand that, you'll never get any questions wrong. Now, if anybody in the audience has any questions, they can ask. If not, I'll make these for everyone else. I'll make these recordings available to you in addition to the slide deck.
Thank you.
Okay, so study hard, and I promise you these things will come up. You'll see them clinically, so be prepared.